Well, thank you for joining me for our central venous access with point of care ultrasound lecture. We are going to take a quick look at some of the ways you can implement this into your current practices, hopefully making your procedures a little bit more safe and efficient and easier for yourselves. Okay, so a couple objectives that we're going to try and have you meet today. We'll have you look at how ultrasound guided catheter placement has helped improve the efficiency and accuracy of central venous placement. We're also going to look at how to enhance success of the practitioner, as we know that practitioners need to be well trained prior to attempting this approach on living humans. And so we're going to provide a little bit of that training for you today. So the use of ultrasound and needle catheter placement really, the origins really started out in the 1980s when they started developing more technology to allow for color and spectral Doppler scanning. At that point, we became more better able to decipher arteries from veins and where veins were located and that type of thing. So it really helped kind of drive the beginning of the possibilities that we're seeing come into fruition now. Over time, the technology improved. Our black and white, or our B mode, got a lot better, so we could see vessel walls more clearly. We could see deeper in the patient. We could also had enough spatial resolution that we could track an actual needle tip. So as this all came together, they started looking for additional ways to utilize this technology, and of course, needle and catheter placement became one of those approaches. So currently, the use of ultrasound in needle and catheter placement is used most extensively in the neck when it comes to accessing the common carotid artery and the internal jugular vein. Now, today we're just going to concentrate on the internal jugular vein in the venous system, but any vessel can be identified under ultrasound and could be theoretically catheterized. So what they found was utilizing ultrasound in these catheter placements demonstrated a high effectiveness at reducing iatrogenic effects of CVC placement, such as pneumothorax and arterial puncture. So now there's certain agencies, the CDC being one of them, the AHRQ being another, that actually institutes the recommended use of ultrasound for CVC placement as the standard of care, because they found that this improves cost effectiveness and decrease in blood infections. So when it comes to the actual procedure, as I mentioned, a little bit of training and a lot of practice is going to make this much easier. There is a lot of hand-eye coordination involved in this process, for instance, we actually have a phantom, making it possible to get some of that practice in before you actually have a patient. If not, you can create different phantoms in your own site that might help you with this. So additional vascular placements that we didn't talk about yet would be we talked about the internal jugular and the common carotid artery, but we know that ultrasound guidance is often used for PICC line placement, as well as subclavian and axillary vein access. Now, in these smaller veins like the subclavian and the axillary, there's not yet any universally accepted recommendations by any associations. They're still looking. There's some evidence-based reporting statements that recommends a certain amount of training prior to using this for those smaller vessels, but you will see clinically a lot of people are attempting to do this, even though it might not necessarily be recommended under certain circumstances. So really quick, we'll do a quick review of the anatomy, because the first thing we're going to talk about is internal jugular vein catheter placement. So when we're looking at our internal jugular vein, it's obviously coming down from our head. It's going to run parallel to this common carotid artery and be very close. It's just lateral to it and parallel. As it comes down inferiorly, as it approaches just posterior to the clavicle, it's going to anastomose with the subclavian vein right in this region. And from there on out, it makes up the brachiocephalic vein until that anastomoses with the other brachiocephalic vein and becomes the superior vena cava. Central venous catheters are typically inserted between the sternal end of the clavicle and the sternocleidomastoid muscle, so right in this general region here. And because of that, it gives the practitioner relatively short access to advance their guide wire from this proximal jugular right into the brachiocephalic and then into the SVC if required. Okay. Now, one thing that can happen that you have to be aware of as a practitioner before you put in the catheter is your good evaluation for thrombus. So we know that very sick patients, they're going to follow Virchow's triad. They're probably going to meet one or more criteria of Virchow's triad, including stasis, hypercoagulability, and trauma. So because these patients, it's common to have one or all three, they're going to be at high risk for clot, and the practitioner would certainly not want to put a catheter right into a clot. And so because of that, when assessing for where the practitioner wants to place the catheter, it's going to be really important that part of that assessment is looking for any type of thrombus that may exist. So thrombus, again, not uncommon in critically ill patients. We can diagnose that like we would any other thrombus in the body from a lack of compression of the vein and from disrupted blood flow. And if we're missing either one of those and our gain, our color gain and our regular BMO gain are accurate, then that could indicate a thrombus, especially if that vein can't compress. And so that would be a contraindication for a catheter placement on that particular side. Okay, so now the technique to the approach. So for all of the neck, especially the internal jugular vein catheter placements, you're typically going to have a very low depth. And so you're going to want to utilize a high frequency linear transducer, usually somewhere between an 8 and a 12. And then before you start the procedure, before you even prep your patient, you're really going to take a scan of both sides, just looking for whatever vein or location is going to be optimal for the procedure. Once you see that you have a preferred side, then it will help to elevate the chin and turn it slightly away about 30 degrees from the side of access. At that point, you can scan that internal jugular vein from superiorly to inferiorly until it, and as you get to the clavicle, you should see it diving back behind the clavicle and anastomosing with the subclavian vein to create the brachiocephalic vein. And at that point, that is where you know that you're going to want to ultimately end up with your guide wire. So make sure that you can see all of those branches or anastomosis before you begin the procedure, so that you know that you can still see where you need to see once you're mid-procedure. So the other thing that you're going to want to be careful of, and I apologize, I have a typo here, you're going to center the IJV, the internal jugular vein, to the center of the display like we see here. And then you're going to slowly move caudally from the patient's chin all the way down to that clavicle, and then angle behind the clavicle inferiorly until you see it anastomose with that subclavian vein. Now here, this is a relatively typical view. It is very challenging to get behind those clavicles. So here you see the right internal jugular vein coming down. It anastomoses with the right subclavian here, creating this brachiocephalic. The other brachiocephalic or innominate comes in here and they create the SVC. So the part that you're trying to enter is going to be into this internal jugular to get into the brachiocephalic. So some of the things that are going to help you decide exactly what part of this jugular you're going to go for the approach is, like we mentioned already, verify that there's no thrombus present. Also, look at the greatest diameter of the vessel. Obviously, if you have a bigger target, it's easier to hit it, so we're going to be looking for the greatest diameter. And then the shallowest site, so we don't run out of needle length to get there. And finally, you want to look for good separation between the internal jugular vein and the common carotid artery, so you don't accidentally penetrate that artery. Now, remember as you're doing this that the angle of incination, or the angle that you're directing the beam, can be adjusted to gain a little bit better access to the site. So if you aren't seeing the vessels quite as you want, sometimes angling down towards the patient's feet will get you farther behind that clavicle. Sometimes maybe taking your transducer, moving the whole transducer underneath the clavicle and then doing a sweep down there might get you a better view. So don't be afraid to move that clavicle around, shift it, angle it, sweep it, in order to try and get the optimal visualization of the vessel that you're looking for. And then once you're finally decided that you have the site that you're prepared to insert the needle, you can use, Sharpie mark or whatever you want to use to mark that site, and so you don't lose it while you're prepping your patient and your transducer. So once you go to prep, obviously you're going to be prepping your patient and prepping your sterile field to get ready for this exam. Make sure that you're setting up the equipment in a comfortable position so that you're not looking at the patient's neck and then having to turn your head to look at the monitor. This physician here did a great job. They've got the patient's head at this end. They're standing at the head so that they can advance the needle downward into the jugular vein. And while they can, with just simply looking up or down, they can watch what they're doing with the needle placement and then how that's adjusting the view on their image at the same time. So it should be about eye level. They're a little bit low here, but his equipment doesn't look that ergonomically flexible. So if you have the ability, of course, you're going to want to bring it up a little bit higher, but the big thing here is to keep it all in the same line of sight. Now, once the patient is all prepped and your physician is the physician is sterile gloved, we want to make sure that that transducer stays sterile. So you need to insert some gel on the inside of the transducer cover, and then you're going to insert the transducer and then use rubber bands to keep that transducer sheath or cover from sliding. And then of course you're going to have to make sure you're double checking and utilizing the sterile gel as well. So once you get to the procedure, it's recommended that you hold the transducer in your non-dominant hand. So, and then you're going to hold the needle in your dominant hand, so you have a little bit more control over that needle. Identify the previous marked spot, and then you're going to add your sterile gel, and then you're going to be scanning in what we're going to talk about first. Most likely will be in transverse. As you get more efficient and well practiced, then you might want to change to long, but transverse is the novice approach typically. So here you see the patient's head would be up here, their neck is here, their body is down here, and the transducer is in transverse, and they are advancing the needle at the center of the transducer. So transducer in non-dominant hand, needle in dominant hand. Make sure you're using sterile gel. Try to avoid the puncture site with your gel. And then as you puncture, ensure that before you puncture, ensure that if you're in transverse, that the mark at the top of your transducer is facing the patient's left side. If you happen to be in long, then you want the mark at the top of the transducer to be towards the patient's head. And that's going to be really important in order to get proper orientation of your image on the screen to the anatomy at hand. Okay, so here for the transverse approach, you're going to have the transducer transverse across the patient's body. This notch that you should see here should go towards the patient's left side. And as the practitioner is entering this needle, they're going to want to enter, if the jugular vein is right in the center of screen, right like it is right now, by accessing that vein in the center of the transducer, it should keep that aligned. Now, the important keynote here with the transverse approach, you're only seeing one cross-sectional image at a time. So you're only seeing this one slice through the neck here. So you'll see the guide wire or the needle on end, but you'll never have a full appreciation of the total length of the guide wire or needle. This is still the preferred approach because, as you can see, the practitioner can kind of watch and adjust their needle approach as they went until they were able to get right into the center of the vessel. So in our transverse approach, it's going to optimize the ability to see the center of the vessel and to know your orientation left to right. However, it can be challenging to know if this little dot is truly the tip or is this little dot a different part of the needle. So that can add a level of challenge there. Again, overall, most consider this the easier approach over the long, and so it's the most commonly used by novices. So when you go ahead and start a transverse approach, center the internal jugular vein in the center of your image, and then access the vessel depth. So you might even want to use calipers. Let's say that this is the skin surface. You're not sure how much of your needle you're going to advance. By taking a caliper measurement from the vessel to the skin surface would give you an idea of how much needle you're going to use, so that if somehow you lose your tip, you're not over advancing that needle into some posterior anatomy like the lung or the carotid or something like that. So once you have your spot located, once you know your depth, then you're going to tilt the transducer toward the operator, and you're going to tilt the bottom of the transducer away towards the patient's feet. Towards the patient's head. Then you're going to insert that needle at the center of the transducer at usually a 45 to 60 degree angle. Now, as you insert that needle, you should see the tip initially, and then as you insert that tip beyond the width, so as this tip goes beyond the width of the transducer, you will lose the view of the tip and just see the bore of the more central bore of the needle. So it's important to stop the advancement and then angle the transducer slightly, and then advance again and angle the transducer, so that you're always trying to keep that tip within your field of view. So you're going to continue to advance and find and advance and find as you progress with the needle until you see that the tip is denting the internal jugular vein. And at that point, you know you're ready to progress and puncture into the vessel. So once you've punctured into the vessel and gotten a flash, there's a couple different ways that you can make sure that you got into the vein, not the artery. And so once you see the tip in the vessel, by turning on color or spectral pulsed ultrasound, you can verify that it's demonstrating venous flow, not arterial flow. At that point, they're going to then have you insert your guide wire. So you'll want to go same approach, or begin feeding the guide wire through the needle system, follow it all the way until it gets to usually the brachiocephalic vein. At that point, you don't want to go any farther until you again use color and spectral to verify that you're in the vein, not an artery. Once that guide wire is placed, then you can go ahead and proceed to standard catheter placement, including a skin nick, dilating, and inserting the catheter. Now, the longitudinal approach is basically the same thing. It's just that we're going to see things differently. So here you see this practitioner is long to the patient's neck. The marked margin would be at the top towards the patient's head. And now, instead of just seeing the tip of the needle, you're seeing the whole length of the needle, if you can. Now, if your hand turns at all, or the needle progress angles at all, what you're going to end up seeing is flashes of parts of the needle, and that's why this can be so challenging. The other thing about this is that if you happen to accidentally sweep your hand towards one side or the other, you're going to be more lateral in the vessel rather than in the center. Like when you saw in transverse, you knew you were in the center of the vessel. So this can be a little bit more difficult in the longitudinal approach to tell if you're really truly in the vessel. A little bit harder to track your needle. But once you get efficient at this, you can actually track the whole needle, and so some practitioners really like this once they become more advanced. So the needle is going to travel along the same plane of the beam, so rather than coming in at a cross section to the center of the transducer, now you're going to come in line with the transducer. It optimizes the ability to monitor the needle through the whole, or in its whole entirety. and it requires a little bit more expertise than in the transverse, as we talked about. So the process of the longitudinal transducer approach is going to be really similar to the transverse. So now, instead of centering the internal jugular vein in transverse, you're going to center it in long, or you're going to center it in transverse and then rotate on it 90 degrees until you have it in long. Make sure that the marked end of your probe is towards the patient's head. Ensure that the transducer is staying in the center of the vessel lumen and that your hand is not wandering or sliding to the lateral margin where you might actually just miss the vein entirely. It can also be easy, since the lateral relationship with the CCA is so close. It's also possible that, without even realize your hand is moving, you can end up in the carotid and puncture the carotid. So make sure you're staying centered to that CCA, to the IJV. If you ever for a moment have a question, flip your color on, look for pulsatility. Remember, you don't want pulsatility in the vein, you want phasicity, so you can always double check yourself with that. Okay, so once you feel like you're in the IJV, then you're going to want to check with color and spectral, ensure that you are in the vein. And then you're going to insert the needle at 45 to 60 degrees at the center of the transducer. And for this one, you're often, if you have a steeper or diving angle, you're going to need a steeper diving vessel, you're going to need a steeper angle. And then, of course, if you have a more superficial horizontal vessel, then you need less of an angle. As you do this, slightly tilt the transducer from the insertion site toward the tip until it's identified. And sometimes you might just have to sweep your hand side to side a little bit, very, very minimal movements, to get that needle centered to the transducer. And once it's centered to the transducer, then you're just going to keep that transducer on it as you advance the needle. You should see the needle tip and shaft in its entirety. If you're seeing pieces of the tip or pieces of the shaft, but not the whole needle, it often requires like either a counterclockwise or a clockwise rotation to get back on its long axis. Once you're watching that needle, then you can feel free to advance it. You won't have to do the adjust approach like we did with the transverse, because the whole needle should be in your image the whole time. So you can advance the needle, making for mild adjustments to try and hit the center of the IVJ as you go. Again, you're going to see a dent once the needle is close to the vein, and then you will puncture and enter the vessel. You can then use the Doppler and spectral approach to verify that you are in the venous system. And then you would then switch out, advance the guide wire down, and then monitor it or follow it all the way to the brachiocephalic vein. Do one more check with Doppler and spectral to ensure it's truly in the vein, and then proceed to that standard catheter placement like we talked about with the skin nick, dilate, and insert catheter. Okay, now you'll see patients more and more frequently with subclavian and axillary vein catheterization. This is less used because it's a little bit more challenging for the practitioner than the internal jugular vein approach or the femoral vein approach for other regions of the body. But this can easily be accomplished once you've got some experience under your belt. So background on this is that the subclavian vein ultrasound guidance was previously limited because of the difficulty in scanning the area due to overlying bony structures. So new data suggests that utilizing ultrasounds for subclavian catheter placement, it significantly decreases complications and the numbers of attempts before success. It can be accessed via either the subclavian vein directly or by accessing the axillary vein, which feeds into the subclavian vein and accomplishes the same thing. Intrajugular catheterization and axillary vein access by anesthesiologists were found to have a similar complication rate, relatively low, of 0.7 to 1.2%. The same study indicated that the axillary approach was initially more difficult, but once mastered, provided safe, reliable results. And some of the things that had an effect on how accurate and useful the axillary catheterization was really directly due to the location, depth, and the surrounding anatomy of the vein. So the anatomy of our axillary vein catheterization, we're just really quick review here of the anatomy. The axillary vein is going to start where we have the brachial veins and the basilic veins anastomosed right here near the axillary region, and then it's going to become the axillary vein until it reaches the lateral margin of the first rib, and at that point that cephalic vein is going to come and anastomose there. After that anastomosis, we're going to call it the subclavian vein, and again that subclavian vein is going to meet up with the jugular, creating the brachiocephalic. The brachiocephalics of both sides join together to produce the SVC. So the process for evaluating an axillary vein catheterization would be to really scan along the whole length of that subclavian and even the axillary vein. Again, we want to make sure that there is no thrombus in here, so the assessment is going to be really important. So if you find the midclavicular line right in this general region, you can start to sometimes see the subclavians kind of reappear out from under that clavicle. By having the patient abduct their arm and rotate into an external position, you can usually follow it into the axillary region of the shoulder here and follow that vein laterally. Once you follow it laterally, you want to see where that cephalic vein anastomosis at, and you will know that that is that transition from axillary to subclavian. So once you see that cephalic vein and you go inferiorly to that, then you're going to be monitoring the compressions and the appearance of the axillary vein until you get down here and you see where it had its origin, where the brachiocephalic, or excuse me, the brachial and the basilic veins came together. All right, now lateral sites should be avoided due to the possibility of brachial plexus or long thoracic nerve injury. So because of that, you want to practice see if you can approach more from the medial side, and again, that's why that patient would have to abduct and externally rotate that arm to give us better access to the axillary region. The ultimate recommended placement is about less than 4 centimeters from the midclavicular line. So while you're taking a look, you're really scanning from that midclavicular line on down, checking through thrombus, coming back up, looking for your optimal placement, but more often than not, they want it at about 4 centimeters from the midclavicular line, right in this region. Once you've assessed that vein, you believe it's the vein, not the artery, you're going to want to make sure to verify that with spectral and color. And then again, really settle in on where you want to take your approach. So the technique for this would be in a plane long to the vessel, follow immediately from the glenohumeral joint right in this region, as they're doing right here, from this glenohumeral joint, and access that axillary vein in long and identify where the cephalic vein comes off, or excuse me, anastomoses with that axillary. At that point, you know you have the origin of the subclavian vein. So this should be right at that margin of that lateral margin of the first rib. Then you can scan an additional 1 to 2 centimeters medially until the cephalic vein anastomoses with the axillary, and then you're going to scan until the distal vein is created at the site of anastomosis with the brachial and basilic. So we kind of already talked about that. You want to make sure all of those are open, no thrombosis, and identify the easiest insertion, which should be, again, at about 4 centimeters from the midclavicular line. Okay, so the technique, once the site of insertion is identified, then you're going to want to, of course, prep your patient. Sometimes, because this is a deeper area, practitioners will utilize some local anesthesia, which you can also track. As you can see right here, this is a needle probably injected the anesthesia as kind of a trial run, and then when you go to insert the catheter, you know that your placement was probably pretty good, so you have a little bit more confidence as you go into that second part of the procedure. Because these vessels are quite a bit deeper, you're going to need a 40 to 80 degree insertion angle. centered to the anterior axillary vein or the wall just at the distal subclavian vein. Angling the needle trajectory that places the first incised ribs anterior to the lung is going to be the best way to reduce the probability of pneumothorax. So by changing your scan angle, you can make the ribs appear in front of the lungs, which help you avoid penetrating that. Advance of the guide wire, again, you're going to get your needle placement just like we spoke about last time. This time it's going to have to be in long. Typically because you can't get your transducer behind the clavicle well and transverse in this region. So it'll be long to the vessel. They'll advance, insert the needle once needle placement is verified with color and spectral, and then they can go ahead and advance the guide wire to the location of choice. Once they're happy, we've checked color and Doppler and ensured that that guide wire was in a vein, then they can go back and do the whole skin, nick, dilate the track, and insert the catheter. Other venous line suggestions, this is just recommendations from people that have gotten involved in placing a lot of these. They say that novice operators should only move one hand at a time during a puncture and placement. So move your scan hand, then the needle, then your scan hand, catch up with the needle, and so on and so forth. And that limits your probability of missing the tip and penetrating something you didn't intend to penetrate. You can also use the depth of the skin to troubleshoot when a venous flashback is not seen. So if you know you've advanced a 3-inch needle and the depth of the vessel was only 1.5 inches and you haven't gotten a flashback, then knowing that distance should tell you not to continue to try and advance the needle, but to pull back as you've probably missed the vessel entirely. Make sure that you don't over gel an area, because that gel can get everywhere and it can make things very slippery, and it can be difficult to grasp onto your transducer, making your progress very much more challenging. Most critical venous verification point of processing is verifying that the guide wire is in venous placement, not arterial. So no matter what your approach is, whether it be internal jugular vein and long, or trans, or subclavian, or axillary, whichever way you do it, they say the most important part is to ensure that the guide wire tip is in the vein. So checking that with spectral and color before actually advancing the catheter is going to be essential. And then finally, venous placement should really be mastered utilizing those big veins like the jugular or the femoral before you go to attempt the smaller veins like the axillary or the more difficult veins because of their location like the subclavian. So hopefully with the right techniques, many practitioners will find excellent efficiency to placing central venous catheters with ultrasound guidance. Novice scanners should begin with the easy ones, which are going to be the internal jugular as well as femoral, where as you get more advanced, then you may want to try your hand at the subclavian vein or the axillary vein placement. So hopefully you're ready to go place some catheters, and have a great day.